Although defibrillation recommendations did not change, there are new recommendations for synchronized cardioversion. For cardioversion of atrial fibrillation, the guidelines recommend that the initial biphasic energy dose is between 120 and 200 joules. The guidelines now clearly recommend cardioversion for monomorphic VT. In those cases, the initial energy dose is 100 joules. The return of spontaneous circulation, or ROSC, is no longer the end of the cardiac arrest protocol. More and more scientific studies conclude that survival rates improve significantly with a comprehensive system of post-cardiac arrest care. That's why the American Heart Association has developed a post-cardiac arrest care algorithm. This can guide hospitals in offering a structured and integrated system of care for patients who achieve ROSC. The goals of the new algorithm are to provide guidance for pre-hospital personnel in transporting the out-of-hospital patient to an appropriate facility with post-cardiac arrest care, provide guidance to hospital personnel for transporting the patient to a critical care unit capable of providing post-cardiac arrest care, identify and treat the causes of the arrest and prevent a recurrence, and optimize cardiopulmonary function and vital organ perfusion, especially to the brain and heart. Other objectives of post-cardiac arrest care include considering hypothermia to optimize survival and neurologic recovery, identifying and treating acute coronary syndromes, reducing the risk of multi-organ injury, gathering data to assess recovery, and offering rehabilitation services to survivors if needed. Brain injury and cardiovascular instability can indicate whether a patient is able to survive after cardiac arrest. Therapeutic hypothermia is the only intervention that has been shown to improve neurological recovery. That's why rescuers should consider hypothermia for any patient who is comatose after ROSC. Several studies show good outcomes for patients whose bodies were cooled to 32 to 34 degrees Celsius for 12 to 24 hours. One study followed cardiac arrest patients who received hypothermia treatment and were comatose on arrival to the hospital. 20 to 50% of those patients had good neurological function 1 year later. Hospital personnel should not delay reperfusion therapy for STEMI patients during post-cardiac arrest care. It is safe to combine PCI and hypothermia after cardiac arrest. Rapid transport to the cath lab remains the focus for STEMI patients. The key interventions for post-cardiac arrest care include induction of therapeutic hypothermia, monitoring with quantitative waveform capnography, acquisition of a 12-lead ECG, monitoring of oxygen saturation values, blood pressure optimization, and determination of blood chemistry values. The next category of changes relates to managing the patient's airway. The AHA has incorporated several new recommendations into the 2010 guidelines. The first is quantitative waveform capnography. Waveform capnography monitors the amount of carbon dioxide exhaled by the patient. It's the most reliable indicator of endotracheal tube position during cardiac arrest. It also serves as a physiologic monitor that provides information regarding the effectiveness of chest compressions, ROSC, and adequate coronary perfusion. The guidelines recommend using waveform capnography to verify the placement of an endotracheal tube. Scientific studies have not yet validated waveform capnography as a method of confirming proper placement of other advanced airways. However, effective ventilation through one of the other advanced airways should produce a capnography waveform. A normal CO2 waveform looks like this: 0 levels in the early phase of patient exhalation. At point B, the first amount of CO2 arrives at the sensor, followed by a sharp rise in CO2 levels. The CO2 concentration during exhalation eventually plateaus. Point D represents the highest concentration of exhaled CO2 with that individual breath and signals the beginning of the inspiratory phase. This phase produces a dramatic fall in CO2 levels. Rescuers can also use waveform capnography to monitor CPR quality and detect ROSC based on end-tidal CO2 values. If the rescuers are effectively ventilating the patient, ineffective chest compressions will produce a low end-tidal CO2 reading. In contrast, ROSC can cause an abrupt increase in end-tidal CO2. Other recommendations that relate to managing a patient's airway during cardiac arrest include cricoid pressure. Do not routinely use cricoid pressure during cardiac arrest. Studies show that this technique is difficult to master and may not be effective at preventing aspiration. It may also delay or prevent the placement of an advanced airway. Agonal gasps are not effective breaths and should not be confused with normal breathing, delaying important life-saving interventions. Across the United States, survival rates for cardiac arrest, ACS, and stroke vary considerably from region to region. It's important that EMS and healthcare providers work together, not only to deliver patient care, but to strengthen the chain of survival for future cardiovascular patients. That starts with identifying the weak points in your system's chain of survival. Gathering data and measuring patient outcomes can identify areas that need improvement. The 2010 American Heart Association guidelines are very clear on this team approach. In order to deliver the highest quality patient care, there needs to be an integration of community, EMS, physician, and hospital resources. This applies acutely to the STEMI chain of survival. If community members are trained in recognizing the signs of cardiac arrest, EMS can be quickly mobilized for patient treatment. An out-of-hospital 12-lead ECG is essential to provide advance notification of a STEMI case to the receiving ED. This advance notification reduces the time from patient's onset of symptoms to reperfusion with PCI or fibrinolytic therapy. The goal is to treat the patient with reperfusion within 30 minutes of arrival to the ED. Because of the time-sensitive nature of the treatment, the guidelines recommend that all cardiac arrest patients be triaged to PCI centers or PCI-capable facilities. In patients suffering a stroke, integration of care is equally important. In these cases, time is brain. The sooner ischemic stroke patients within the appropriate time window can receive fibrinolytic therapy, the higher their rate of neurological survival. Much like patients with acute coronary syndrome, the chain of survival starts with bystanders recognizing the symptoms and activating the emergency response system. EMS providers evaluate the patient and alert the receiving hospital if they suspect a stroke. EMS providers should transport the patient to a stroke-prepared hospital if possible, where they offer best practices of comprehensive stroke care. If the diagnosis ultimately reveals an ischemic stroke, the hospital has 3 hours from the onset of symptoms to administer fibrinolytic therapy. The 2010 guidelines recommend that whenever possible, EMS should triage the stroke patient to a hospital where stroke care is offered. Patients experience improved survival rates, better functional outcomes, and quality of life when treated by a hospital specializing in stroke care. The American Heart Association recommends all eligible patients receive fibrinolytic therapy as soon as possible within the first 3 hours from symptom onset. For a selected group of patients, the fibrinolytic treatment window has been extended from 3 to 4.5 hours. At the time the 2010 guidelines were released, this treatment window was not FDA approved, but it is recommended by the American Heart Association and the American Stroke Association Science Advisory. So let's recap the changes to the ACLS guidelines. The AHA simplified the adult cardiac arrest algorithm. The circular algorithm can help minimize interruptions in high-quality CPR or delays in defibrillation attempts during cardiac arrest while integrating IV access, drug delivery, advanced airway placement, and the treatment of underlying causes at strategic brief pauses. The AHA no longer recommends atropine for the treatment of PEA or asystole. The treatment of cardiac arrest no longer stops at ROSC. New post-cardiac arrest guidelines optimize cardiopulmonary function and vital organ perfusion, especially to the brain and heart. ACLS providers should consider hypothermia for every patient who remains comatose after ROSC because it is the only intervention that has been shown to improve neurological recovery. Quantitative waveform capnography can reliably confirm the placement of an ET tube and monitor CPR quality as well as ROSC. Finally, integrated systems of care should include community members, EMS, physicians, and hospitals in order to deliver the highest quality patient care. In the 5 decades since chest compressions were first attempted on a cardiac arrest patient, there have been significant improvements in the treatment of acute cardiovascular disease. There is much more work to be done. With the latest research pointing to new, quantifiable ways to improve patient outcomes, advanced providers have more tools than ever before to reduce death and disability caused by cardiovascular diseases and stroke.